Hello everyone. So now we will be doing the part 3 of our rapid revision, which will be covering anatomy, menstruation, menopause and urogynecology. Okay, so let's start it. First of all, we will be doing here anatomy of the fallopian tube. First thing which I would like to tell you that in the fallopian tube there are peg cells. Okay, these are typical cells which are found only and only in fallopian tube, and they are named as peg cells, and their function is not known. Okay. Next is that the fallopian tube is divided into four parts. If we go from medial to lateral, that is, if we go from the uterus to the ovarian side, the fallopian tube is divided into four parts: interstitium, isthmus, ampulla, and infundibulum. The interstitium part is the most narrowest part, and it is the part which is inside the uterus. Okay, so this part is supported by the myometrium. Usually in the anatomy, one liner question comes, so I would request you to learn these all one liners by heart. So in the interstitium is the narrowest part of the whole fallopian tube, and it is supported by myometrium. The isthmus is the second narrowest part, and it is also known as physiological sphincter. The ampulla, listen carefully, ampulla is the most widest and the most lengthy part. Okay, it's the most widest and it is the most lengthy part, and it is also a site of fertilization. Okay, infundibulum has no typical characteristic, just that much that in infundibulum at the end there are fimbriae, and it catches the ova at the time of ovulation. Okay, now let's study the epithelium of all the genital tract at one time. Okay, now the epithelium of the ovary is flat cuboidal. Okay, all those organs which functions a bit less, okay, they have a cuboidal cells. So the epithelium of the ovary has got only one work, that is that it has to undergo ovulation. So when the ovulation occurs, the Graafian follicle bursts, ova goes into the fallopian tube, the epithelium has to get teared. It's only one function in 1 month. Okay, so the cells of the ovary, as they have less function, so their cells are cuboidal in shape. Okay, the cells of the fallopian tube and uterus epithelium is columnar. All those organs which have got the function of secretions, which secrete something or which are glandular, they have columnar epithelium. So fallopian tube, uterus and cervix, as all of them secrete something, so they are columnar, or you can say due to their secretions they become columnar in shape, lengthy in shape. Okay, now the fallopian tube epithelium is columnar in shape because it secretes watery secretions. Okay, that is why in the fallopian tube cancer lot of watery secretions are there. Okay, and these also have cilia. Okay, they are ciliated columnar. Anything which has to move some products, or some which has to make something move, will have cilia. So fallopian tube have to move the fertilized ova into the uterus for the implantation, and the uterus has to move the menstrual blood out of the endometrial cavity. So both fallopian tube and uterus, they have ciliated columnar epithelium. Okay, so endocervix has the epithelium because endocervix secretes cervix secretes mucus. You all know cervix secretes mucus. So cervix secrete mucus. Okay. So its cells is columnar, and they are very tall because mucus is somewhat mucin protein and makes it very tall, very high columnar are they. Okay. And it is asked that it is high columnar or low columnar. So endocervix is high columnar, or you can say very tall columns are there. Okay. Only these two epitheliums are asked in exam: fallopian tube and endocervix. Okay. Ectocervix and vagina, as they are exposed to atmosphere more than the other reproductive tract, they are you can say stratified squamous. All those parts which are exposed to the outer atmosphere, our buccal cavity, anus, genital tract, and this ear canal, all these parts which are exposed to the outer atmosphere have got a squamous or stratified squamous epithelium. Okay. And you have to keep one thing in your mind, that it is non-keratinized, because if it would have been keratinized, then we would have got in ectocervix and in the vagina skin. As there is no skin, so it is non-keratinized stratified squamous. Okay. For all those who still cannot remember, just ratta, the fallopian tube is ciliated columnar and endocervix is tall high columnar. Okay. Let's move to the anatomy of the uterus. So uterus has different parts. The upper part of the uterus is known as the fundus. Now you will think that my this fist is uterus, this part is fundus. These the parts from where these two fallopian tube come out are cornua, and this is the body of the uterus. The part which narrows in the last is known as cervix. Okay, you all know. Now on the size of the uterus is the main reproductive organ. Many times question have come. So there is a mnemonic: 3 inch into 2 inch and into 1 inch, 3 into 2 into 1. So as you all know, 1 inch is the equal to 2.5 centimeter. So its length is 7.5 centimeter. This whole length of the uterus is 7.5 centimeter. This breadth of the uterus, the width of the uterus is 5 centimeter, and this thickness of the uterus is 2.5 centimeter. Okay. Something interesting about the uterus is that this cervix and corpus ratio. We think that always the corpus is body of the uterus. We always think that the corpus is always long and cervix is small. It is not so when the female is in childhood or before puberty. It is opposite. Okay. This is, so it is this much long. Okay. So the cervix is double the length as compared to the body or corpus when the female is child. Okay. So uterus is corpus length is uh, half of the cervix length. Okay. So you can see that this much cervix is here and the corpus. So when a lady female grows at puberty under the influence of the hormones, FSH, and the estrogen, progesterone, the uterus grows, the corpus grows, and the corpus grows, the uterus body grows, and it becomes doubles the size of the cervix. Okay. So when a female is child or before puberty, the corpus is half of the length of the cervix. Okay. So I have drawn something here. You can see this is the uh, just a minute. Yes. So this is the uterus of the, yes, this is the uterus of the this is the uterus of child, where cervix is very long and the uterus corpus or the uterus body is very small, and this is a pubertal female where the corpus is long and the uh, cervix is small. So the ratio is 1 is to 2 in the childhood, and puberty the ratio is 2 is to 1. Usually they only ask in the childhood. Okay, now let's go to the next slide, which is about the lymphatic drainage of the cervix. You all know that the cervix cancer is very common in India, right? So the lymphatic drainage is very essential as to know. It gives us the knowledge of lymphatic drainage of cervix is very important, and questions do come on these important topics. Okay, so we have to learn this by the mnemonic HOPS. Lymphatic drainage of the cervix, I have already told you in oncology. H stand for hypogastric or internal iliac lymph node. O stand for obturator lymph node. P stands for presacral or paracervical or parametrine or ureterine lymph node. So it all of these they mean the same. Okay, this is a one group of lymph node which has so many names, so you're not going to confuse yourself and not going to blame me that ma'am you didn't taught us. Okay, presacral, paracervical, parametrine or uterine lymph node. Okay, E is external iliac lymph node and S stand for sacral lymph node. So most commonly cervix drain into obturator lymph node, and the sentinel lymph node which is involved in CS cervix is the P1. So O is the most common and P1 is the uh, most sentinel lymph node. These days they are saying that external iliac lymph node is common. New knowledge says that external iliac lymph node is a sentinel lymph node. So you just see the option. Okay, if external iliac lymph node is given, do give preference. If external iliac lymph node is not given and they have asked what is a sentinel lymph node, so then do mark presacral lymph node. Okay, if both are given, presacral and external iliac both are given, then mark external iliac. It means examiner want to know you that whether you know this thing or not. If external iliac is not given and only presacral is given, then mark the presacral. Okay, never involved inguinal lymph node, never involved cervix, never drain into inguinal lymph node. Okay, but if the CA cervix patient inguinal lymph nodes are also involved, then it means that he that patient is cancer has metastatized, because itself the cervix doesn't drain into inguinal, but if the inguinal lymph node are involved, it means the cancer has metastasized, and the stage is 4B. You know, in the last stage the whole body can get involved. Okay, okay, so let's go to the next slide, which is about the uh, vagina. Okay, so first very interesting thing about the vagina is that vagina has no glands. Okay, and as we already studied that vagina epithelium is stratified squamous. If it would have been glandular, then its epithelium would have been columnar, right? But as it is exposed to the outer atmosphere, its epithelium is stratified squamous and there is no glands in it, right? Okay, the it is mainly then from where does the vaginal secretions come? It comes from, mainly comes from the cervix. When I put this question on the telegram, you all mark Bartholin gland. Okay, so Bartholin gland secretion comes only during the intercourse beta. Okay, not always, not always a person does intercourse. Okay, so Bartholin gland helps in lubrication. So it's during the intercourse. So its secretion will come only and only during the act. Okay, so as such, the vaginal secretions come from the cervical secretions. They pour down into the vagina, and that act as a vaginal secretions. Okay, now when a child grows, when a child attains puberty, female child attains puberty, you know that estrogen hormone, it circulates into the female body, and that estrogen hormones does some effects on vagina. Okay, and estrogen and progesterone hormones, they do come and enter the vaginal cells. Under that effect, under that influence of the estrogen, under that influence of the estrogen and the glycogen, body glucose glycogen, it enters the vaginal cell, and due to that glycogen, borderline bacilli comes and resides in the vaginal cells. Okay, once again, when girl gets attains puberty, estrogen estrogen hormone circulates into the body, and this estrogen hormone, it attracts the it allows the entries of the glycogen into the vaginal cells, and this vagina cells, it resides the good bacteria, the bacilli. And what does this bacilli do? It converts this glycogen into mannose sugar. This bacilli, it metabolizes glycogen into mannose and lactic acid, and this acid, lactic acid, which is produced by the borderline bacilli, it makes the vagina of a pubertal female acidic and prevent the vagina from infections. Okay, once again, I would like to uh, tell you that when a female attains puberty, the there is a estrogen hormones, it circulates into the whole body. This estrogen hormone in the vagina, it allows the glycogen entry, and the glycogen attracts the borderline bacilli, which is basically a good bacilli. So this borderline bacilli, it metabolizes glycogen into mannose and lactic acid, and this acid makes the vagina pH acidic, and the pH becomes or in the childhood the pH is 6 to 8, but in the puberty and reproductive age this pH becomes 4.5. In pregnancy, there is more estrogen, so more lactic acid is produced, and pH falls more acidity is there, pH becomes 4. Okay, now what about the lymphatic drainage of the vagina? As you know, we have done the Mullerian chapter. You know that cervix and vagina, upper two-third, comes from the Mullerian duct. So what all is the lymphatic drainage, nerve supply, blood supply of the cervix uh, is the supply of the upper two-third vagina. Okay, so these are some concepts. If you make it, then you will learn it easily. Okay, otherwise anatomy is very difficult, I know that. Okay, so the lymphatic drainage of the cervix and the upper two-third vagina, the blood supply and the nerve supply of cervix and upper two-third vagina is same, and lower one-third vagina and is that of same of the vulva. Okay, so upper two-third vagina has same lymphatic drainage that of the cervix, so its lymphatic drainage is hopes, hypogastric, obturator, parametrial, external iliac and sacral. Okay, and lower one-third is the one which was never involving the cervix, which was from which cervix was never draining, inguinal lymph node. Okay. Okay. Now let's study some anatomy about the vulva. All the external genitalia is known as the vulva. of the female is known as the vulva. Labia majora, labia minora, and vestibule. You all know what is labia majora and labia minora. Once again, I would like to tell you what is vestibule. The all the opening of the female internal genital tract, the area which is inner to the labia minora, right? The opening and what all structures are there inner to labia minora is known as vestibule. Okay, so you're not going to confuse yourself. What is vestibule? All the structures inner to labia minora is known as the vestibule. Okay, and what is the lymphatic drainage of the vulva? Again, it is seen that of the lower one third of the vagina, it is inguinal lymph node. Very peculiar thing about the very peculiar thing about the labia minora is that the labia minora doesn't have any hair follicles. No hair grows on labia minora. No sweat glands are there. Only and only sebaceous gland are there. So all these things which are very particular, do examiners do ask. So today I told you that three typical things I told you. Number one is that fallopian tube has special cells, packed cells, whose function is not known, but yes, they do have. And next is the vagina. It has does not has its own glands, right? And number third thing which I told you is there is no sweat glands and no hair follicles in the labia minora. Okay, so it only has sebaceous glands. Okay, so, large vestibular gland or the Bartholin gland, you all know this. Large number of questions come on this gland. They are present in the vestibule, and it's duct open at the junction of anterior 2/3 and posterior 1/3 of the vestibule. Okay, I think I have to erase something. Okay, I will erase this part. You just see what is written here, that the prostate gland in the male is homologous to Skinner's gland in the female. Okay, and this labia minora, it is homologous to the the Bartholin gland, it is homologous to the Cowper gland or bulbourethral gland. Okay, these homologous things are also asked in exam. They are less important clinically, but they do ask, so you can just remember by their position. Okay, prostate gland is homologous to Skinner's gland, and the Bartholin gland is homologous to bulbourethral or the Cowper's gland. Okay, so now I am erasing this thing to make you understand the opening. Okay, so if yes, yeah, if this is the vestibule and this is the introitious or the vaginal opening, so this is vestibule. So this is anterior 2/3 and this is posterior 1/3. So here the Bartholin ducts, it opens. So this is also known as 5 o'clock 7 o'clock junction. So I described you this in detail because they do ask, they do give you the images of Bartholin cyst. So the cyst, the abscess which is in the vestibule area, and it is located at near toward the posteriorly, is the Bartholin cyst. Okay, okay, then its opening are opening inner to the labia minora, or you can say its opening are opening, Bartholin duct is opening into the, you can say, vestibule or a groove inner to labia minora at posteriorly at 5 o'clock 7 o'clock position. So this is asked in which and where does the Bartholin duct opens, so that you should know where the cyst is formed. Okay. Okay, now what is the treatment of it? Is the treatment of this marsupialization. What we basically do in in marsupialization, I would tell you what is incision. What is IND? IND is, for example, this is a swelling, so you will give a incision and you will drain all the matter. That is IND. So simple. You all will do in your first year post graduation. Many INDs you get. Okay, and what is marsupialization? For example, you uh, I have to draw it, right? So I will draw it. And in which all we do marsupialization, let me tell you. For example, if this is swelling, okay, so we give the incision like this, okay, then I remove this whole part, whole covering of swelling, okay, and I remove this whole part. So this will not will be. I remove this whole part, and finally I will change the pen. And finally I stitch this left. So very widely I cut the pus area, pus covering, and then I stitched the edges with the sides. So what advantage is there with this marsupialization? The advantage is that now this cavity will remain open and it will not close. It is done in all those cysts which reoccur again and again. So it is in this way cavity it remains open. So now whenever it will reoccur, the pus will drain off. Okay, so that is why marsupialization is done in Bartholin cyst, because it do reoccur and patient has to then suffer again from that surgery. Okay, so marsupialization is done. Here we remove a covering of the swelling and then we stitch the edges with the incision. Okay, so let us study the last topic of the nerve supply of the anatomy, that's the nerve supply. The nerve supply of the uterus is T10 to L1. Okay, from the T10 segment to L1 segment, the uterus nerve supply is coming, and the cervix nerve supply is from S2 to S4. You all have to learn in the NEET PG 22. A full question has come on the innervation of uterus. So if you are going to learn, there are high chances that this time in FMG the question will come on the nerve supply of the uterus. So I always say you, the NEET PG and INICT, they decides the new topics. Okay, so if you are the one who are sensitive for the new topics, so this is one of the topic, nerve supply. Okay, it's more or less cramping the topic. Ratification is there, lot of ratification is there, but yes, it's an important topic now. Okay, so uterus get its nerve supply from T10 to L1. The cervix get it from S2 to S4, as I already told you. Vagina upper two-third will again get from S2 to S4, and vagina lower one-third will get from pudendal, and vulva is also pudendal. So I already told you that cervix and upper vagina will be same, as both of them originate from, and vulval and lower vagina are same. Okay, and the in the early labor, when the cervix is not dilating, or you can say the latent phase, the pain received by the patient is only from the uterus. So it is from T10 to L1 segment, and in the late labor when cervix dilates, it is this uterus plus cervix both in the late labor. Okay, epidural is given at T10. Okay, epidural. So epidural analgesia, we give epidural analgesia for the painless delivery. So we have to give the epidural at T10 segment, because then the epidural analgesia drug, it goes into the all the rest of the lower segments. Okay, anesthetists give it in T10 and then the drug goes down under the gravity. So all the lower segments are relieved from the pain. So the level is T10, and in spinal we give the spinal at we take out the pain from all the segment below T4, because whenever we are doing cesarean we give spinal, and then we are also handling the peritoneum, right? So peritoneum has also to get pain free. So this in spinal anesthesia or in the cesarean, the pain in fact should go below T4, but in the epidural no need to go such high, because there we're not handling in normal delivery we're not handling any peritoneum. So the pain should get मतलब पेन T10 से नीचे नहीं होनी चाहिए, तो फिर पेनलेस डिलीवरी हो जाएगी, ठीक है। वेन एवर वी आर डूइंग फोर्सेप और वैक्यूम, वी आर अप्लाइंग फोर्सेप और वैक्यूम और इंस्ट्रूमेंटल डिलीवरी, then the that cervix is dilated, all the contractions have taken place, then the pain will be only in the lower vagina and vulva when we are applying the cervix, when we are applying the forceps or vacuum. So then we have to give pudendal nerve block. It is given at ischial spine, where pudendal nerve goes and it gets blocked by that drug, and usually the ligament which is pierced while giving that block is sacrospinous ligament. Okay, so pudendal block is given in while we do the instrumental delivery, and forceps or vacuum, because there the pain is only in the vagina, lower vagina and the vulva, and there we block only the and there we localize the ischial spine and give that analgesia drug over there. Okay, and during the episiotomy we give local anesthesia. Let's move to the next chapter, which is menstrual cycle. Now you all know menstrual cycle means monthly cycle, the cycle which is going monthly. So basically there are two types of monthly cycle. The one which is occurring at the level of the ovary is known as ovarian cycle, and the one which is occurring at the level of the uterus is known as the uterine cycle. Okay, so what happens in ovary? The ovarian cycle is divided into two phases. Number one is the follicular phase. As you will come to know that under the effect of the FSH, the follicle grows in the first 14 days. It is known as follicular phase, and then the ovulation occur, and then the corpus luteum is formed in the last 14 days. So the last 14 days phase is known as the luteal phase, and the first 14 days phase is known as the follicular phase. In the uterus, in the first 14 days the endometrium proliferates. Okay, what does you mean by proliferate? Endometrium grows. So the first 14 days are known as the proliferative phase. Then comes the dominancy of the hormone progesterone. What is the action of progesterone on the endometrium? Progesterone does not let the endometrium to proliferate more, to grow more. So it is known as stabilizing effect, and it makes that grown endometrium, so it stops the endometrium from growing. So it stabilizes the endometrium, and it also makes the endometrium secretory. Okay, secretory. The endometrium is filled with secretions. Okay, or all those secretions. Okay, so this is in short about the ovarian cycle and the uterine cycle. Now let's study these cycles in detail. So this is the hypothalamus. Okay, this hypothalamus secretes GnRH. Okay, and this GnRH, it acts on the pituitary, anterior pituitary, and it secretes gonadotropins in FSH. Okay, this FSH act on the ovarian ovarian ovaries, this ovarian follicles, and it grows this follicles. Okay, so this FSH act on this ovarian follicle, so the follicle grows. Okay, and it produces estrogen, and this estrogen, it makes the endometrium proliferative. Okay, so now this endometrium, it has started growing, proliferation. Okay, so this happens in the first 14 days. And when the, so you can see here, this is the how the hormone FSH varies in the 28 days. Okay, so see, this hormone increases in the first 3 days, then the hormone level decreases, then again it increases at the 14th day, FSH surge at the 14th day, again it decreases. Okay, so the gonadotropins, whether it is FSH or whether it is LH, both are both the gonadotropins, they have surges means sudden rise, surges. Okay, so as you have seen here, there is a sudden rise, and here again there is a sudden rise. Okay, that is not so with the ovarian hormone, the estrogen. So you know that FSH stimulates the ovarian follicle, and this then ovarian follicle synthesizes estrogen. See, this estrogen is increasing in a slope like manner. Okay, is increasing in a slope like manner, right? So this estrogen is increasing and then it starts decreasing, it decreases also. So its peak is attained at day 12. The estrogen peak is attained at day 12, and then this estrogen, once this estrogen peak is attained at day 12, then two significant things occur. Okay, then two significant thing occur when its peak is attained, then two significant thing occur. This estrogen has a negative feedback effect on FSH when its peak is attained on day 12. Okay, and this estrogen has a positive feedback effect on the FSH, sorry, LH, positive feedback effect on the LH. मतलब estrogen increase will let the LH increase. Okay, so this estrogen peak and the values are almost 200 picogram per ml. Okay, no need to learn these values, you just learn that estrogen peak is at day 12, and once the estrogen get this peak, then FSH decrease is and LH increase. Okay, now as I already told you, all these surges, sudden rise are seen in the gonadotropins FSH and LH, and whereas the estrogen and progesterone, they have a slope like growth. Okay, graphs. Okay, now what happens, now what happens, now LH surge occurs. Okay, yeah, here. Okay, now this blue, just a minute, let me move this camera, yeah, here. Okay, now this blue graph is of the estrogen, as I already told you, always say with the sloping graph. This is of the estrogen, this is slope, this is of estrogen, and this is surge, this is of LH. So LH was less initially, and it rise at day 12, sudden rise is there, and then LH falls, and then it's at a higher, more level, but it is still high than the follicular phase, and then it decreases after the day 22. Let me tell you how. Okay, so see here, there is a sudden rise of the LH at day 12 when estrogen attains its peak. I told you there will be the LH surge. So now I have depicted the surge here beautifully. Okay, see this curve. Yes, so this is LH. I know. Now this surge is of the LH. This surge. this sudden rise of the LH is for 48 hours. Okay, this whole duration is 48 hours. Okay, and the peak, which is almost in the mid, is achieved after the 24 hours, 12 and 12 24, because this is in the mid. Okay, this peak, this is in the mid, so it is comes after 24 hours of the LH. Peak is after 24 hours of the LH surge. ठीक है, 12 and 12 24. सो बिकॉज ये पूरा 48 आवर्स का सर्च था, तो बीच में आ रहा है पीक, तो यानी 24 आवर्स पे आएगा. ठीक है, अब जब ये LH फॉल करने लगता है, लेकिन अभी भी ये इसका लेवल ज़्यादा है. ठीक है, जब फॉल करने लगता है तो हेयर or ovulation occurs. This red sign is of ovulation here. In midway during its fall, LH levels are falling in, but they are but it is a part of the surge. These levels are high but less than the peak. Okay, so here ovulation occurs, ova is released at this time. So what is the duration between LH peak and ovulation? It is 12 hours. Okay, and what is the duration between LH surge and ovulation? This is LH surge started here. And what is the duration between LH surge and ovulation? Here ovulation was occurring, so 36 hours. So that is what I want to tell you, because you all people get lot of confused here. Okay, that the duration between the LH peak and the ovulation, this is 12 hours, and the duration between the LH surge and the ovulation, this duration it is 36 hours, and the LH surge whole is for 48 hours. Okay, so now I think with this you will be able to differentiate what are the all the graphs. So the graphs which have surge, which have two surge like this, it is of FSH. Which has only one surge like this, it is of LH. And the graph which has two slopes like this, it is of estrogen. And the graph which has only one surge, I have drawn it late in the later slide, which has only one slope in the luteal phase, is of the progesterone. Okay, now LH starts releasing. Now LH surge ovulate, this ovulation occurs. So this ova is released and this corpus luteum is formed. Okay, this corpus luteum is formed. Now this corpus luteum, it after ovulation from this follicle, this is again occurring in the ovary. This goes into the fallopian tube, and this corpus luteum, it synthesizes progesterone, and this progesterone, it makes the endometrium secretory. Now this whole endometrium is filled with glands. Okay, so soon the progesterone corpus luteum dies at day 26 to 28, and then no progesterone is there, and then progesterone and estrogen withdrawal both leads to menstrual cycle. Now let's see, there are two types of cell division. You all know, if the cell has to divide, okay, there are two types of cell division. Okay, mitosis and meiosis. Human cells are diploid. So if mitosis occur, from one cell two cells are produced, and both will be having the diploid chromosome number. And in meiosis, from one cell four cells are produced, and this diploid cells, and all these four cells will be of haploid. In meiosis 1, only two haploid cells are formed, and in meiosis 2, from this haploid cells, four cells are, now two cells, each haploid cells will make two more cells. So meiosis 2 is equal to mitosis. Okay, so now let's study the oogenesis. Okay, so as you all know, the The woman who gives birth to a child, उस child की मम्मा होती है. The grandmother is known as दादी माँ, right? So in the similar way, the starting structure is known as the oogonia. The starting structure is known as oogonia, and उसका भी जो starting होता है, it is known as epiblast. So it is a question, very important question. Epiblast. Epiblast is the structure from where oogonia originates. So this is very, very important. Please. Okay, epiblast is the origin structure. Okay, and oogonia is a diploid. Oogonia is diploid. It is 2n, has 2n chromosome number. Now this oogonia undergoes mitosis, and it forms for mitosis same chromosome number structures are formed: diploid, primary, oocyte. So primary oocyte is again diploid. Okay, now this primary oocyte, it undergoes meiosis 1, and this meiosis 1 is arrested at prophase 1. The meiosis 1, at every mitosis, meiosis 1, meiosis 2, all this have 4 phases: prophase, metaphase, anaphase, telophase. This meiosis 1, prophase 1 is gets arrested. Okay, here the cell division gets arrested, it gets locked, and then this lock is opened by LH surge at the puberty. Okay, and then and this LH surge just is accompanied by ovulation. So when this meiosis arrest is open, then from the primary oocyte, the secondary oocyte is formed, right? This primary oocyte, after the division, ideally there should be 2 haploid cell, but when meiosis 1 occur, you have studied after meiosis 1, 2 haploid cells are formed, but here it is not like that. After meiosis 1, 1 haploid cell, secondary oocyte, and 1 polar body is formed. So here they ask, when is the first polar body formed? So in another words, they want to ask you that when is that arrest opened? The lock which occurred in the meiosis 1 at the prophase 1 diplotin stage, when is the lock opened? The lock is opened at the time of the ovulation by the LH surge. Okay, so you have to learn this term. It is accompanied by at the time of ovulation. Sometimes they ask you just before ovulation. No, at along with the ovulation, and this lock is opened by the LH surge. Okay, now after the completion of meiosis 1, one polar body and one secondary oocyte is formed. Okay, now this secondary oocyte, it undergoes meiosis 2. Again arrest occurs, lock lag gaya, again a lock occur. Now this time the lock has occurred in the metaphase stage. So we will say that secondary oocyte has been arrested at metaphase 2 stage, and now when the sperm enters the oocyte, okay, then this lock is open. Few hours after the sperm entry into the ovum, this lock is opened. Okay, and now when this lock is open, this secondary oocyte, which is haploid, forms oocyte, a proper oocyte, ovum, and a second polar body. So now again they don't ask you when meiosis 2 arrest opens, they ask you when second polar body is formed. Second polar body is formed just after the sperm enters or just at the time of the fertilization. Okay, so these are the 2 common questions which they ask. More questions also come whether the primary oocyte is haploid or not, or haploid or diploid. So primary oocyte is diploid, secondary oocyte and the oocyte, they both are the haploid structures. Both the polar bodies are haploid structures, and oogonia forms primary oocyte by mitosis, and which undergoes meiosis 1, primary oocyte undergoes meiosis 1, which undergoes meiosis 2, secondary oocyte undergoes meiosis 2. So these are some basic things which they keep on asking, so you should have knowledge of this. That is why I've covered the whole slide here. So the special questions which are asked in gynae is that when is the first polar body formed? The first polar body is formed at just at the time of ovulation, and the second polar body is formed just at the time of the fertilization or when the sperms enters the oocyte. Okay, now the synthesis, now you know that now you know that oogonia forms primary oocyte, and the primary oocyte they get arrested and the uh, prophase 1 diplotin stage. Okay, now this primary arrested now this arrested primary oocyte it has its own home that is known as follicle. Okay, so what is follicle? Basically, you know that ovary is filled up with follicles. Follicle is the home of oocyte. And what is primordial follicle? Primordial follicle is the first follicle which is formed, and where the primary oocyte rests in the uh, diplotin prophase 1 stage. Okay, so all the oocytes they are formed in the intrauterine life, and maximum oocytes are there in the female body at 5 months or 20 weeks of the intrauterine life, and that number is 7 million. At the birth that number becomes 2 million, and at puberty it becomes 5 lakh. So I always remember 7 minus 2 equals to 5. You can also remember like this. Okay, 7 minus 2 equals to 5. Yeah, camera is here. Okay, so I think now one more basic thing is clear to you. What is the difference between the follicle and oocyte? Follicle is the home of the oocyte where oocyte rests. So in the primordial follicle, the primary oocyte which is having the arrested primary oocyte in the diplotin prophase 1 stage is residing in it, and the maximum number of primordial follicles is at the 5 month of intrauterine life or 20 weeks, and at birth it is 2 million, and then at puberty it is 5 lakh. Okay, now let us see, we studied in the menstrual cycle that the follicle grows. Now let us see, I think you all know that in December 2021 the question has come on antral follicle, so I have drawn all the stages. Okay, so first is this is the primordial follicle where the primary arrested primary oocyte is residing. So it has only one layer of cell around it, roughly one layer of cells around it. So this is known as primordial follicle. Now what is primary follicle? If that oocyte is surrounded by granulosa cells, if that is surrounded by granulosa cell or one layer of cell, then it is known as the primary follicle. Then it is known as the primary follicle. And what is secondary follicle? The secondary follicle is when it is surrounded by both granulosa cell and the when it is surrounded by both granulosa cell and the theca cell, then it is known as the secondary follicle. Okay, and this is the stages we studied during that in the follicular phase. Follicle grows. How follicle grows? First of all, the primordial follicle become primary follicle, that is the whose primary oocyte is surrounded by granulosa cell. Then later on this primary follicle is surrounded by two layers of cells, granulosa cells and the theca cells. Then later this secondary follicle has cavity in it, and it is known as antral follicle. Okay, antral follicle, and then the whole matured follicle, which is a big antrum. I haven't drawn it, so you just see the image in your book. So the big follicle, which is big antrum and surrounded by two layers, granulosa cell and theca cell, is known as Graafian follicle. Its size is asked. Its size is 18 to 20 mm. This size is very important. Please learn it by heart. Once it has come in FNG, it can do come again. Okay, so the stages of the follicular growth is primordial, primary, secondary, antral, and the last is fully mature is the Graafian follicle, 18 to 20 mm in size. Okay, now in short about the proliferative phase. Proliferative phase, you know that estrogen is formed by the granulosa cells we have studied, and the granulosa cells form estrogen. This estrogen acts on the uterine endometrium. It proliferates, it grows, the endometrium grows in length. Here in the below figure I have drawn that endometrium. Okay, and at the end of the proliferative phase, it is fully at the end of the proliferative phase, that is at the end, in the 14th day. Estrogen peak was on the 12th day. So at the end of the proliferative phase, it is seen as triple layer endometrium. What is triple layer endometrium? We will see that the triple layer endometrium means, see that this is the endometrium of one side of uterus, right side of the left side of the uterus, and this is the endometrium of the left side of the uterus, and in between is this endometrial cavity. So this is known as triple layer endometrium. A good proliferated endometrium is seen on ultrasound as triple layer. Okay, so this is one layer. Okay, this is the third layer, this is the one layer, this is the third layer, and this in between, this is a second layer. Okay, this triple layer endometrium is seen at the in a good proliferative endometrium. This is of important this is immense importance for the IVF, all those docs who are doing the IVF, because on a good triple layer proliferated endometrium only embryo can implant. Okay. Okay, now next is the luteal phase. Okay, just give me 1 minute. Next is the luteal phase. Okay, continuing, let's continue it. In the luteal phase is you all know that ovulation occurs, and then the corpus luteum secretes progesterone. Now this is the graph of the progesterone. Okay, so if there is only one slope in the last 14 days, slope, not the surge, then that graph is of the progesterone. Okay, and this corpus luteum and this corpus luteum forms three hormones. You all know that corpus luteum synthesizes progesterone, and it also synthesizes estrogen. Now the curve of this, I told you how to identify that this is a estrogen curve. You will identify the two curves, one curve in the follicular phase and one curve in the luteal phase, right? This is estrogen. This estrogen was secreted by granulosa cell, and this second curve of estrogen, this is secreted by corpus luteum. Okay, continuing with our series. Okay, this luteal phase is, so this is the progesterone curve. Okay, and corpus luteum synthesizes three hormones. So when I put this question on the telegram, that corpus luteum synthesizes progesterone, estrogen, both, none, so many of you did wrong, but I think now you know that, most of you know that the corpus luteum synthesizes progesterone, estrogen, both. And in addition to the progesterone, estrogen, corpus luteum also synthesize inhibit inhibin A. Okay, in addition to estrogen, the corpus sorry granulosa cells, they also synthesize inhibin B. So पहले फेज में inhibin B synthesize होता है granulosa cells की मदद से, दूसरे फेज में inhibin A, उल्टा है, बी पहले आता है और ए बाद में आता है, ठीक है. सो व्हेन वी वर लर्निंग दिस फैक्ट्स, वी रिमेंबर दैट हमेशा उल्टी चीज़ें ही होती हैं, सीधी सीधी नहीं होती हैं मेडिकल में, राइट. सो इनिबिन बी इज सिंथेसाइज्ड in the follicular phase, and inhibin A is there in the luteal phase. And you all know that inhibin in the follicular phase, granulosa cell secretes. So inhibin B is secreted by the granulosa cell, and inhibin A is secreted by the corpus luteum. Okay, when a lady get pregnant, then this corpus luteum also synthesizes one more hormone, that is relaxin. Okay, so progesterone, what is the function of progesterone? Under the effect of estrogen, the endometrium was growing a lot. Now under the effect of the progesterone, the endometrium will stop growing, it will not grow, okay, not proliferate. Now it means that stopping the growth of the endometrium is known as stabilizing the endometrium, no further proliferation, no further growing of the and it also make this endometrium secretory, endometrium fully get secreted. Now first step, which you first sign, which you will see on the histopath, okay, under the microscope change, is a subnuclear vacuolation. As these days it is a trend to ask the image question. So you can see that this is the nucleus, this blue one are the nucleus. I am drawing it more of the endometrial cells, right. This is the nucleus, and just above them here, this is a white structure. So these are the vacuoles. So subnuclear vacuoles will be seen, that just near the whole cell will be comprised of two things. Here will be the nucleus like this, and whole endometrium cell will be made of only two things. So this is nucleus, and this will be the vacuole is white in color. So like this, all the cells will be like this. So subnuclear vacuolation is the first change which you will see under histopath in the endometrium under the effect of progesterone. Okay, because what is the effect of progesterone? It stabilizes and makes endometrium secretory. endometrium cell full हो जाते हैं secretion से, तो secretions के लिए vacuoles बनेंगे ना, vacuoles, ठीक है, वैक्यूल्स बनते हैं, फिर ये वैक्यूल्स सिक्रीट करते हैं, या सिक्रीशंस ग्लैंड से वैक्यूल्स में आती हैं, ठीक है. तो वैक्यूलेशन होना फर्स्ट स्टेप है एंडोमेट्रियम के सिक्रीटरी होने का, और ये वैक्यूल्स न्यूक्लियस के जस्ट नीचे बनते हैं, इसलिए इसको सब न्यूक्लियर वैक्यूलेशन बोला जाता है. ओके, और भी हर दिन एक नया चेंज आता है. सो इफ़ वी आस्क द हिस्टोपैथ, द पैथोलॉजिस्ट people, we give the people the endometrium, this pathologist people, and we ask what is the day of the secretion, they can tell you, because day 16 day 15 the change is subnuclear vacuolation, day 16 it is some another change, day 17 it is some another change. So every day some change comes. So we are not going to read the all, we are only going to read subnuclear vacuolation, that is the first change. Then slowly the secretions will come, and in the last there will be corkscrew glands. Okay, now let us discuss the corpus luteum of the normal and the pregnant. Okay, so first of all, let's see of the non-pregnant or the normal female, the corpus luteum. Okay, the corpus luteum grows to its peak. Corpus luteum size increases, is much more, and grows to its peak at till day 23. Okay, so you can see here, this is progesterone. Okay, so corpus luteum, who was maintaining the corpus luteum? Okay, we as students are maintained by our parents, right? uh, right. So who is maintaining? LH is responsible for the life, or LH is maintaining the corpus luteum, right? And this corpus luteum is synthesizing the progesterone. Okay, so when till so, who is maintaining corpus luteum? LH was maintaining corpus luteum. So, when the progesterone attains its peak at day 23 of the menstrual cycle, or day 9 of ovulation, whatever it is, both are the same day 23 of the menstrual cycle and day 9 of ovulation. So, when this peak is attained by the progesterone peak is there, now this progesterone peak, it gives a negative feedback effect on LH. You know that estrogen gives the negative feedback on FSH. In the similar way, the progesterone peak at day 23, it gives the negative feedback effect on the LH, and now LH starts decreasing, and as a result the corpus luteum starts synthesizing less progesterone, and when LH becomes zero, then the corpus luteum expires. Okay, so who was maintaining the corpus luteum? LH. When the corpus luteum progesterone gets its peak at day 23, the corpus luteum maintains hormone LH due to the negative feedback effect of the progesterone. Once LH start decreasing, as a result, well, when totally becomes zero at day 26, the corpus luteum expires. So by this discussion you come to know that the luteal phase is fixed, right? It is fixed. The follicular phase is depend on the follicle estrogen, right? It can vary, but the luteal phase is fixed because corpus luteum life is more or less fixed, right? So whenever you have to calculate the day of ovulation, then you have to in the cycle length you have to minus 14, because the luteal phase is fixed. Day of ovulation is equals to cycle length minus 14. Okay, day of ovulation is equals to camera was there, just a minute. So day of ovulation is equals to cycle length minus 14. Okay, because luteal phase is fixed, corpus luteum life is, now you know it's fixed. Progesterone will achieve its peak at day 23, and then the corpus luteum will expire once the LH is at the lowest level 0. Then the corpus luteum will expire, dies off at around at 10 to 12 day or day 26 of the periods. Okay, now let us discuss what happens in once this ovum gets fertilized. Now when the ovum, okay, just one thing more, when the corpus luteum expires at day 10 to day 12, the progesterone falls, and the estrogen which was synthesized by the progesterone also falls. So this progesterone, falling of progesterone, leads to menstruation. Okay, this simple basic can also be asked. What leads to menstruation? Progesterone and estrogen withdrawal leads to menstruation. Mainly progesterone withdrawal leads to menstruation. Now we are here we will be learning the the pregnant lady corpus luteum. The life of the non-pregnant lady corpus luteum is 10 to 12 days, but life of the pregnant lady corpus luteum is 10 to 12 weeks. Okay, so instead of days it changes into weeks. We all studied just recently that when LH decreases, the corpus luteum expires. Who is maintaining this corpus luteum of pregnancy? So here comes the another question, that HCG maintains the HCG maintains the corpus luteum of pregnancy. How it maintains the structure of the HCG, the beta subunit of the HCG is similar to that of the LH, TSH, and FSH. Is similar to that of the LH, TSH, and FSH, but the function of LH and HCG is almost same. HCG and LH, this function is same and structure same. So this was a question was asked in FNG. HCG is structurally and functionally similar to, so the answer was LH. Okay. So once again, I would like to tell you the lifespan of the corpus luteum in a pregnant female is 10 to 12 weeks, because the HCG, which is secreted by syncytial trophoblast cell of the fetus, it secretes, it maintains the corpus luteum because its function is similar to that of the LH and structure is also similar to that of the LH. Now let's discuss here the ovulation test. So you all know ovulation tests are of important in infertile female. So we need to know that whether the fault is at the ovulation or tubal factor is there. So to check whether the ovulation is occurring or not, so we make that female to undergo ovulation test. So there are a lot of ovulation tests. So you all know that if LH get rise on day 14, yeah, if LH surge occurs, then the ova will rupture, then the follicle will rupture and ovulation will occur, but that rise is for a very limited period and we cannot catch that light, and this test is not so much good test. Okay, so LH surge test is of the high values of that peak. LH peak is only for few hours, 5 to 6 hours, and we don't know, it can vary from woman to woman. So LH surge test is not a good test at day 14. Okay, so we all know that LH surge causes ovulation, you know. I can support this fact also by one thing. You all know in PCOS LH is very high and still the patient is not ovulating. Okay, so again the LH surge is not a good test. Okay, so yes, it is one of the tests, one of the tests, but it is not a good test. Okay, because LH peak is only for 5 to 6 hours, and we don't know in which 5 to 6 hours we have to get the sample done. And in PCOS, the most common cause of anovulation, the LH is high but still no ovulation is occurring. So this LH surge is not a good test. Yes, but it is one of the tests. Okay, so now we all know that if ovulation occurs, then corpus luteum will form, and this corpus luteum will form progesterone, and its peak is on the day 23. So if we calculate the if we check the progesterone on day 23 of the regular cycle, then and if its value is more than 3 nanogram per ml, it means that the ovulation has occurred. Okay, so progesterone is a good test because progesterone is synthesized by corpus luteum. So corpus luteum will be only formed if ovulation has occurred. So this is one of the good tests, serum progesterone, to calculate the serum progesterone at day 23. Okay, when it is at its maximum, so day 23. Then we can also undergo cervical mucus studies. You all know that under the effect of the estrogens, the mucus is thin and salt thin, and it shows spin bucket effect, and under the effect of the progesterone, this spin bucket effect it get lost at day 18. Loss of spin bucket effect at day 13. Okay, loss of spin bucket effect at day 13, sorry, day 18. Okay, at day 13, the spin bucket effect or the fern pattern due to the NaCl it comes. You all are doing right, so I'm not stressing on this point. Okay, so under the effect of the estrogen, spin bucket and fern pattern come on the slide. Okay, and then it get lost on day 18. If this gets lost, it means now progesterone is there, and it means that the female has ovulated. Endometrium, we can also see whether the endometrium has that progesterone changes, that secretory changes in the endometrium or not. And this is a very good test, in very good test, in सब में से सबसे अच्छा test है that we see the endometrium under the histopath, and if there is secretory activities present in the endometrium cells, that secretions are present in the endometrium, it means the progesterone is synthesized and ovulation has occurred. The serial ultrasound, in ultrasound we see that follicle, the 20 mm follicle or two, and after the 14th day we see whether the follicle has ruptured or not. Okay, so that was all about the menstrual cycle and ovulation test. So now we will be studying about the dysmenorrhea. Okay, now dysmenorrhea, what is dysmenorrhea? This is again something very basic thing, and so we are studying here in the menstrual cycle phase. What is dysmenorrhea? You know that, I know that you all know that the pain felt during the period is known as dysmenorrhea. Now let me explain you it biochemically, that when the ovulation occurs, prostaglandin F2 alpha is released, and this F2 alpha is released, and just before the just after the there is estrogen progesterone withdrawal leads to menses, right? You all know that estrogen and progesterone withdrawal leads to menses. This progesterone F2 alpha, which was released at the time of ovulation, now this progesterone of F2 alpha, it come in front at the time of the estrogen and progesterone withdrawal, and it contracts the myometrium of the uterus, and it opens the cervix, so that from now this opened cervix the endometrium can shed. Okay, once again I would like to tell you what is dysmenorrhea. At the time of ovulation, progesterone F2 alpha is released, and this F2 alpha come in front at the time when estrogen and progesterone withdrawal occurs. Till that it cannot act, this F2 alpha cannot act. Okay, it only act at when estrogen progesterone withdrawal occurs, and then it, what is the function of F2 alpha? You all know that it contracts the myometrium, of the uterus, and it opens the cervix, and from now this open cervix, this endometrium can shed. Okay, this contraction causes the pain. Now this contraction of the myometrium, it causes the pain. That is why it is said that that is why dysmenorrhea happens in all the females. Okay, so dysmenorrhea is of two types: primary dysmenorrhea and secondary dysmenorrhea. Okay, primary dysmenorrhea is due to prostaglandins, which was secreted ovulation, and it opens the endometrium on estrogen progesterone withdrawal, and it is only on the day 1 of the periods. Okay, it is only on the day 1 of, only for 1 day this pain happens. Okay, this duration is very important. Basic things are quite asked very commonly. Okay, so please learn that primary dysmenorrhea is due to the prostaglandins F2 alpha, and it is only on the day 1, and it occurs in all the females. And the treatment of choice for the primary dysmenorrhea, once you have diagnosed that it is a primary dysmenorrhea, is NSAIDs, and or second drug which we can also give is antispasmodic. If it is not treated by NSAIDs and antispasmodic, the other drug which we give is OCPs, oral contraceptive pills, because in oral contraceptive pills no ovulation occurs, so there will be no prostaglandin and no primary dysmenorrhea will be there. Okay, now secondary dysmenorrhea, in addition to that, and if any underlying diseases is there, then there is much more pain. So in addition to this prostaglandin factor, if some underlying diseases is there which are causing very excessive pain, more excessive than the day, one day. So in the secondary dysmenorrhea, pain is for the whole menstrual cycle, the 4 days of the period pain is there, and stays till menses are there, occur one day before and stays till menses. So एक दिन पहले ही शुरू हो जाती है, पूरे menses में रहती है. So long duration pain, and due to some diseases, the most common diseases which cause a secondary dysmenorrhea is the endometriosis and PID. Okay, so what is the treatment of secondary dysmenorrhea? Of course, treat the diseases. Okay. Okay, so now also we are again covering the topic premenstrual syndrome. What is premenstrual syndrome? That just before the menses, few days before the periods, now some abnormal symptoms come in a female, then they are known as premenstrual syndrome. What is premenstrual syndrome? Just before the menses, if some abnormal symptoms come in the female, 3-4 days before the menses, then it is known as premenstrual syndrome. There is what are those symptoms? Depression, headache, weight gain, bloating, low energy, breast tenderness. They come to such a high level. Small amount of PMS occurs in all female, but if they occur so much, the symptom severity is so much that they are affecting the life of the female, then it is premenstrual syndrome. And the treatment for this is SSRI, selective serotonin reuptake inhibitors, duloxetine, and we have also to increase the immunity and increase the nutrition level. The typically vitamin B6 and calcium is given to the patient of PMS. Now let us study the effect of estrogen and progesterone on the body. Okay, so in the vagina, we have seen that vaginal pH is due to the estrogen effect. I'm not going to read it again. And due to the estrogen, the cells, there is one complete layer of cell is due to the estrogen, that is superficial cell layers. It comes only when estrogen is there in the vagina, and it goes in the menopause completely. Okay, and progesterone is responsible for the basophilic cell layer, and it is known as intermediate. Okay, so if we take the vaginal smear, if we prepare the vaginal smear, and if we get the superficial cells which are eosinophilic cells, if we see the eosinophilic cells in the microscope, it means that the estrogen is there in the vagina and the female is undergoing through the proliferative phase. And if we see the basophilic cell, it means that the female is going through the progesterone in the vagina. Okay, now you all know that cervix mucus is thin, watery and elastic, shows a spin barkage effect due to the estrogen, and the cervical mucus is thick and scanty under the effect of progesterone. On endometrium change we have discussed in details. A little more thing is that cardioprotective, this estrogen is cardioprotective, that is all the females, in spite of the fact the males they have more MIs before 40 than the females. Okay, the ratio is 1:9. Female to male ratio of MI before 40 years is 1:9. That males are 9 times more prone to MI than the females, because this estrogen is cardioprotective. You all know that estrogen is also osteoblast, has an increased osteoblastic activity, and estrogen we have studied that it maintains the levator and eye tone, and it also maintains a lower genitourinary epithelium. And this progesterone is a thermogenic hormone, that is one of the tests of ovulation, that when ovulation occurs progesterone is released, and that it increases the temperature by 0.5 degree Fahrenheit or 0.2 degrees centigrade. So the progesterone is a thermogenic hormone, and progesterone also is makes the uterus quite quiescent, not let the myometrium to contract, and that is why it is also given in a patient with a history of preterm labor pains. So that was all about the effect of estrogen and progesterone. Mm, this is something about the normal menstrual cycle length. So normal length of the cycle is 28 days, but plus minus 7 days is considered normal. That is 21 to 35 days cycle is said normal cycle. Okay, normal blood loss in the bleeding days is 30 to 80 ml, and the normal bleeding days are 4 to 6 days, and menorrhagia is increased bleeding in bleeding days, or bleeding days are more if the blood is more than 80 ml is lost, or the bleeding occurs for more than 6 days, then it is known as menorrhagia. Hypomenorrhea is decreased bleeding. Okay, so as 30 to 80 ml is a normal blood loss, so if it is less than 30 ml, then we say it hypomenorrhea. Okay, oligomenorrhea is that the cycle length is increased if the cycle length between the length of the cycle between the two menses cycle, it is more than 35, it is oligomenorrhea. Most common cause of oligomenorrhea is PCOS, and it is called polymenorrhea if the cycle length is less than 21 days. Frequently menses come, bleeding days come frequent, bleeding days are at a wide gap, it is known as oligomenorrhea. Metorrhagia is normal bleeding is occurring, but in between spotting is occurring. What is the cause of metorrhagia? Polyp, right? Polyp. And what is menometorrhagia? Menometorrhagia means that menorrhagia plus metorrhagia. Metorrhagia is intermenstrual spotting and irregular bleeding, you can say. Rather, you can say intermenstrual spot. Yeah, you can say intramenstrual spotting, or you can say irregular bleeding. Anytime bleeding occurs, small bleeding occurs anytime, along with heavy bleeding days. Menometorrhagia. Okay, so these are some of the definitions. Now let us study the menopause. Okay, what is menopause? Pause of the menses. You all are familiar with this topic much more. So when periods stop in total, then we say it that menopause has occurred. No monthly cycles and menopause. FSH now. Oh, it is basically that all the follicles have depleted. So when there is no follicles, so though FSH will be there, brain is synthesizing FSH, but no estrogen will be formed. No estrogen will be formed because there is no follicle after a fixed age, and it is this menopause age is 48 years in India. In India, it is 48 years, and in all over in the world it is 51 years. So they can ask you, it has been asked in your very past FMG exam, that menopausal age in India is 48, and in the whole world in journal it is 51. Okay, so menopause occurs when all the follicles get deplete. Okay, and if there will be no follicle, in spite of the presence of FSH, no estrogen will be formed, and then no periods will be there. So to diagnose a lady at the age of the menopause, if there was amenorrhea for 12 months or 1 year, then we will say that it is a menopause. Okay, to diagnose a lady as menopause has occurred, at least 12 months amenorrhea should be there. Okay, so first change that occurs is that serum FSH rise. So FSH rise in the perimenopausal lady, first change that occurs is serum FSH rise, because it is not that suddenly all the follicles get depleted. Okay, so follicles get decreased in number with age. With the depleting follicle, the FSH rise. Okay, now what are the hormones level in the menopause? As you all know that serum estradiol and progesterone was giving the negative feedback to FSH. Serum estrogen at its peak give negative feedback to FSH, and serum progesterone at its peak on day 23 gives a negative feedback to LH. Now there are no estrogen and progesterone, so no negative feedback, so FSH and LH increase. So what is the hormones? Level increased FSH and LH and decrease estrogen and progesterone. Okay, once again, decrease estrogen and progesterone and increase FSH and LH diagnose menopause. And out of this, if we say one test which says yes, menopause has occurred, then that is FSH. Okay, and if its value is more than 40. Okay, what are the symptoms of menopause? The symptoms are hot flushes, this, and of course no periods, prolapse uterus, osteoporosis, senile vaginitis, and the cardioprotective effect has lost. Okay, what is the treatment? Of course, now we know that all these effects are due to estrogen withdrawal. We give the patient HRT or estrogen. To all those patients who have uterus, we give estrogen and progesterone both. To we give progesterone so that the endometrium does not proliferate, and progesterone can stabilize that grown endometrium. So HRT mainly comprises of the hormone estrogen, and if the menopausal lady has not undergone hysterectomy, then we give estrogen and progesterone both. And if that lady has undergone hysterectomy and uterus is absent in it, then we give only and only estrogen. Okay, so this estrogen is much excess as compared to this estrogen amount as compared to OCP. This estrogen is very high, rather I can say that it is 10 to 100 times, right? 10 times, okay, of that of the 100 times that of the one estrogen tablet is having 10 to 100 times that of the OCP pills. Okay, and after the age of 60 years, please focus here, after the age of 60 years we cannot give estrogen or HRT because HRT is not cardioprotective after 2-3 years. Okay, HRT is not cardioprotective. Estrogen is cardioprotective, but estrogen in such a excess amount is not cardioprotective. So after 60 years we are not going to give the lady HRT. So this question has been asked again and again. It can be asked in your exam. Much expected question is this: after 60 years no HRT because such a high level of estrogens are not cardioprotective. Okay, at that age, if a patient of menopause come at age 60 years, then we are only going to give bisphosphonate or raloxifene to cope up with the osteoporosis. Okay, but we cannot give the estrogen to the female. Okay, now let's come to the urogynecology. Now let's study prolapse. Okay, now you all know that uterus is supported by some structure, that is why uterus is not getting prolapse. So all those structures which are main supports are known as the primary support. There are three main primary supports: uterine axis, muscular support, and the ligament support. Once again, there are three main supports, primary supports. Which are the main supports are known as primary supports: uterine axis, and there is angle of anteflexion, the angle which is made by the uterus axis and the cervical axis is known as angle of anteflexion. All those students who are having problem in understanding these concepts can go to my detailed video, as we are doing revision here, so I have to be a bit fast. Okay, so and what is angle of anteflexion? The angle between the uterine axis and the cervical axis, and this angle is near about 120 to 170 degree, and the angle between the cervical axis and the vaginal axis is anteversion, and this angle is 90 degree. The anteflexion is maintained by round ligament and anteversion is maintained by uterosacral ligament. Some of the students quote me that, ma'am, in our notes round ligament has been written maintains anteversion, but a round ligament maintains anteversion, but uterosacral is the main ligament to maintain the anteversion. So anteversion by uterosacral, and round ligament is for anteflexion. Anteflexion is 120 to 170 degree, and anteversion is 90 degree. Okay. And one thing more I would like to tell you, one of the student only told me that, ma'am, in your anatomy notes it is specifically written these two things. Okay. So muscular support is by the levator ani, transverse and perini, and the deep perini. And then the third support is a ligament support. The main ligament, the triradiate ligament, is the ligament which is supporting the uterus, and it comprises of three ligament: transverse cervical ligament, the one which goes transverse from the cervix to the pelvis bone, and the uterosacral ligament goes posteriorly from the cervix posterior end to the pelvis bone, a pair of ligament. And pubocervical ligament goes from cervix anterior end to the pelvis in front. Okay. So pubocervical, uterosacral, and the transverse cervical ligament are these, all these three ligaments are the known as the triradiate ligament. Okay. And muscular support is by three muscles mainly. All the muscles which are below the uterus are the muscular support, but main muscular support is levator ani. And out of all these three supports, out of the ligament support, muscular support, and the uterine axis, out of all these three support, the main muscular support is the levator ani. Okay. So that is a question I gave in the quiz. Only I get only 40% correct answer. So once again I am going to tell you here that levator ani is the main support out of the all supports. Okay. Secondary support, which supports a uterus, but their support is much less than the primary support, and that is a round ligament. And no support is by the broad ligament. Okay, question come more on these points. No, secondary support is round ligament, no support is given by broad ligament. Okay. Now, as I told you that the levator ani is the main support of the uterus. Okay. Okay. And anything which stretches the levator ani will cause prolapse. Okay. And this levator ani has two tones: neural tone and estrogen tone. What do you mean by tone of the muscle? Tone means its contractility, its power is maintained by two things: the nerves which are supplying them, and number two is the estrogen hormone. So that is why after menopause prolapse occurs. Okay, because the levator ani has two tones: estrogen tone and the neural tone. Now when this neural tone is hampered, okay, more the lady more the lady gets pregnant, more the lady more the is the levator ani stretched. More the lady gets pregnant, more the levator ani gets stressed, and more the lady gets into the labor pains, more the levator ani gets stressed. Because in the whole pregnancy, who is supporting the fetus? Uterus is not such a strong. The levator ani ने अपनी गोद में उठाया हुआ यूट्रस को. Okay. So if you have seen in my telegram channel diagram, the levator ani is a hammock, एक झूले की तरह ऐसे करके. ये बीच में यूट्रस है, ऐसे ना, ऐसे. ठीक है, बिल्कुल ऐसे ऐसे ना, यूं यूं आसपास ये सारी लेवेटर एनाई है. ठीक है. और आप ये देख रहे हैं बीच में ये यूट्रस है, ये पेन यूट्रस है, और ऐसे लेवेटर ना एकदम ऐसे ना झूले की तरह ऐसे उठाया हुआ है. ठीक है. और जब ये यूट्रस प्रेग्नेंट हो जाता है तो ये लेवेटर एनाई पे बहुत बहुत स्ट्रेच आता है, और लेवेटर एनाई वीक हो जाते हैं. विथ एवरी प्रेगनेंसी द लेवेटर एनाई गेट्स वीक. मोर इज द लेडी पैरस, more are the chances of prolapse uterus, that is levator ani gets weak. More the lady undergoes labor pains, more are the chances because who is bearing those pains? Again, levator ani. Okay, and when the estrogen tone is lost, for example in the menopause, again the prolapse occur. So all the factors which are causing the which are affecting the levator ani will cause the prolapse, which will make the levator ani weak, will cause the prolapse. Now let's study the classification of uh, uh, uterus prolapse. Okay, uh, this is a Shaw's classification. Okay, Shaw's classification says if the cervix of the uterus is above the introitius. Was it an introitius? Introitius is the opening of the internal genital tract. So if the cervix is above the introitius, it is first degree. Second degree, if the cervix is at the introitius, and if the cervix is below the introitius, it is third degree. And procedentia, or the fourth degree, is if the fundus of the uterus is also below it. Okay, now along with the uterus, it is not that only the uterus gets prolapse, the vaginal wall also get prolapse. So if along with the uterus the vaginal wall is also getting prolapse, then it is known as the vaginal wall prolapse or vaginal prolapse. Okay, so if the upper two-third anterior vaginal wall gets prolapse, then along with the vaginal wall, the bladder, which is in close relation with the upper two-third wall, also get prolapse, then it is also known as cystocele. Along with the lower one-third, the urethra also gets prolapse, and it is known as urethrocoele. And the treatment of cystocele and urethrocoele is anterior colpo. Colpo word means vagina, refi means repair, anterior vaginal wall repair. Okay, and if posterior upper one-third vaginal wall gets prolapse, then enterocele occurs. Then if middle one-third vaginal wall gets prolapse, then rectocele occurs. And if lower one-third vaginal wall gets prolapse, then perineum get laxed or loose, whose enterocele is repaired by the Moshowitz surgery, and the rectocele and the lax perineum, they both are repaired by the posterior colporrhaphy. Okay, posterior colporrhaphy. Okay, so that was all about the vaginal wall prolapse. Okay, now what is the treatment of the prolapse in the nulliparous lady? So as you all know, you all have done this correctly, that the treatment of prolapse depends on the age and parity. If the lady wants to conceive more, then we have to undergo sling surgery. By a sling, we will tie the uterus or the cervix. Okay, it is also known as cervicopaxy. So it can be put in ray sling surgery or Schrodger's or whatever sling. It will be a sling surgery. Just with the help of a sling, we will tie the uterus so that it does not fall down. Okay, if family is completed but its age is less than 40, then we will undergo Fothergill or Manchester repair. Now, how we remember her if the family is completed and age is less than 40, then this Fothergill and Manchester मतलब वो फादर मदर बन गए. फैमिली कंप्लीट है मतलब वो फादर मदर बन गए. जितनों के भी फादर मदर बनना था, एक के, दो के, तीन के, जितनों के भी बनना था बन गए. सो उनकी उसके बाद जो है हम जो सर्जरी कहते हैं फादरगिल एंड मैनचेस्टर. एफ फॉर फादर, एम फॉर मदर. ठीक है, व्हाट वी डू बेसिकली इन द Fothergill and Fothergill or Manchester repair is basically, as age is less than 40, we don't remove the uterus, we just remove the cervix. We amputation the cervix and we fix the uterus, the uterus whose cervix has been amputated. We fix that uterus to the uterosacral ligament. Now, as you all know that this lady who has undergone this Fothergill or Manchester repair now cannot not conceive because the cervix holds the baby. So now when there will be no cervix, then the baby will fall off, right? Preterm labor pains will occur, or or you can say second trimester deliveries will occur, right? Abortion will occur. So what we do basically in Fothergill and Manchester repair, or the ladies who have completed their family but their age is less than 40, so I am the ideal candidate. If I have prolapse, I have undergone the Fothergill and Manchester repair. In this, cervix is cut, not the uterus, and the cervix is fixed with the uterosacral ligament or the Mackenroditz ligament. Okay, whatever most strong is a Mackenroditz ligament. That is why we prefer to fix it with Mackenroditz, but sometimes we are not able to. If we are not able to fix it with Mackenroditz, we do fix it with uterosacral. Okay, so but preferred are Mackenroditz. So one of the natural ligaments we do, we fix the amputated cervix वाला uterus को हम उससे fix कर देते हैं. And if the family is completed and age is more than 40, then we go for the vagina. We remove the uterus, vaginal hysterectomy, which is known as the ward myo. Ward myo means वृद्ध माँ. अगर कोई माँ वृद्ध हो गई है, बूढ़ी हो गई है, ऑफकोर्स उनकी फैमिली कंप्लीट हो गई होगी, और फिर हम जो है वॉर्ड मायो हिस्टेक्टमी कर देते हैं. ओके. Now, if a patient comes after menopause, as you all know that levator in eye has a estrogenic tone. Yes, estrogen, levator in eye has its estrogen tone. Now, if a lady comes, which come to you for with prolapse, has some mild risk for anesthesia, then we don't do the surgery, because this prolapse surgery takes 30-40 minutes. Then we, if it is has a mild risk and anesthetist told us there's a mild risk, you just do whatever you want in 5 to 10 minutes, then we do Lee forte colpoclasis. Lee forte colpoclasis. Now, how we remember this? I told you that we remember whose family is completed, यानी and age is less than 40, यानी वो जितनों के फादर मदर बनने थे बन गए, Fothergill और Manchester पे. And if the family is completed and age is more than 40, वृद्ध माँ. Okay. Now this third type is, that is anesthesia people, they have put a if. No, you cannot do a surgery. Okay. Now, लेफिर. So what we tell to anesthesia people, लेफिर colpoclasis तो करवा. मतलब you are telling that you do it in 5-10 minutes. We can't do hysterectomy in 5-10 minutes. So लेफिर, ली forte, ली forte, लेफिर तू colpoclasis तो करा 5-10 मिनट में, ठीक है ना. So that's what happens. Yeah, and though anesthesia people are telling in good faith of the patient only, but we get disheartened. The lady will suffer prolapse, and we are not able to do the vaginal hysterectomy. So Lee forte colpoclasis is if the anesthesia people is giving any F, but then it is the Lee forte colpoclasis. What is do? Simply we fuse the interior and posterior vaginal wall. So now the uterus cannot come down, because now these walls they have fused. Okay. Now, if the anesthesia people they give it's much higher risk, you can't do any surgery for 5 minutes also, then we put the pessary. Okay, pessary is a ring-like structure. We also put this pessary if the anesthesia people they don't give fitness, or if the lady is pregnant in the emergency. That was a question of the Zoom 2022 exam, or in the postpartum period where hysterectomy can't be done. Okay, so there are 4 conditions for putting the pessaries. One is if the patient is so high risk that anesthesia people are not giving the fitness. If the lady is pregnant, in the early pregnancy up till 20 weeks we can put the pessary. In emergency we can put the pessary, and in the postpartum period when the lady cannot undergo hysterectomy, we can. So now when we have put in the pessary, as you all know, every female has a different size of the vagina. It can be small vagina, it can be large vagina. So we have to see whether pessary is proper fixed or not. So we check it by Valsalva maneuver. We ask the patient to cuff. So if that circle, that ring is of smaller size, then the ring will fall off with cuffing. Okay, and if the ring is of larger size, then it will create discomfort. Okay, and we also check it by asking the patient to pass the urine, as we have studied that sometimes cystocele and erythrocele occur. So it is quite possible that when we are putting the pessary, and if it is tight, then it can obstruct the urine passage. So by these 3 things, So we will ask the patient to do Valsalva maneuver, because if the ring which we have put is of less size, of is smaller size than that of the vagina, then the ring will fall off. It's loose, right? Right. And if the ring is that we have put is much larger size, then the patient will feel pain in the vagina, right? Something is obstructing. And if the ring is obstructing that urethra, then the patient will not be able to pass the urine. So after checking all these three things, then only we say, yes, now your pastor is comfortable, now you can go. Now let us study about the decubitus ulcer due to the venous congestion at the introitus. Now, when the uterus prolapse, uterus come down, okay, then the veins of the uterus, they also come down. So it is not only that the uterus comes down, the veins of the uterus, they also come down, and now this venous congestion, and now the blood cannot go up at the introitus. So what is the cause of the decubitus ulcer? It is venous congestion at the introitus. I know I'm a bit fast. If you're not understanding any topic, please do refer to my detailed videos, because here I'm bound to be fast because it's a rapid revision class, right? So the treatment of this is, let me draw and tell you. See, because there are chances this question will come. See, now this is the introitus. Okay, now the uterus has prolapsed. This uterus has come down here. Now this is the introitus, opening of the vulva. Along with the uterus, the veins, they also come. Now they get congested here. You know na? This, yes. Uterine artery, they go parallel both sides. Now these uterine veins, they get congested at the introitus, because introitus is a very very narrow opening, and due to this venous congestion, now the veins, venous supply cannot go back because it has been congested at the introitus. Now to treat this decubitus ulcer, we have to reposition the uterus. Now when we will reposition, we will put the uterus inside, then the decubitus ulcer will get treated. Okay, and then because it is a prolapsed uterus, it will again come down. So that it doesn't come down, we have to either put packing or we have to put pessary. Okay, to maintain that position of the uterus, which we have done manually, we have to either do packing, or we have to pack the vagina, or we have to put pessary so that the uterus doesn't come down. Okay, so what is the cause of decubitus ulcer? Venous congestion at the introitus. And what is the treatment of the decubitus ulcer? Repositioning, followed by maintenance of that repositioning by packing or pessary. Okay, all these things are done by the first year. This pessary, placement of the pessary, and the decubitus ulcer packings, all of this. If one of you will go in the gynae residency, I know now people don't like, but still some are having their choice. Some boys and girls are having their choices gynae. So if any one of you go, you will do all these things in the first year. I think in the first month itself. Okay, pessary placement, decubitus ulcer packing. So now let's study urinary incontinence. It's a very very important topic. So what is the meaning of urinary incontinence? You all know that we have a control on micturition. We micture it only when we are in the loo, and if that control goes, it is known as urinary incontinence. What is urinary incontinence? Urinary incontinence is leakage of the urine at an inappropriate time, unsuitable time. Okay, that is when we don't want. the loss of the control on the micturition is known as urinary incontinence. Okay, stress incontinence is that when the urine leaks whenever a lady coughs or whenever the abdominal pressure gets rise. So that is known as stress incontinence. On coughing or laughing, same thing was asked. And what is urge incontinence? Urge incontinence is that urine leak whenever I have a urge, otherwise it doesn't leak. When I have a urge of getting urine, the urine leaks. Before I go to the low, urine leaks. Okay, for example, I have the urge now and I was going to the low, in between the urine gets leaked. Okay, that is known as urge incontinence. On having the urge, the urine leaks is known as urge incontinence. And on having the stresses, cough and laughing, on increased abdominal pressure, the urine leaks, it is known as stress incontinence. Let's study something in detail about this, because this is a hot shot favorite topic of the examiners. What is the physiology of micturition? You all know, when the bladder is getting filled, okay, then sphincter, external urethral sphincter of the urethra is closed and bladder muscle is relaxed, right? So who is closing that external urethral sphincter? Alpha adrenergic supply. Okay, okay, or sympathetic supply. Okay, so you all know, when the bladder is getting filled, this external urethral sphincter is closed. That is why bladder is getting filled, right? And the bladder is relaxed. And who is keeping that sphincter closed? The sympathetic supply or the alpha adrenergic. Okay, when we are micturating, the sphincter opens and the bladder muscle contract. Now who is contracting that bladder muscle? Cholinergic supply or the parasympathetic supply. Okay, now basically what happens in the stress incontinence is that the external urethral sphincter is weak. External urethral sphincter is weak. And and basically, what is external urethral sphincter? It is levator ani. And you all know, all the ladies undergo menopause. So after menopause, all ladies external urethral sphincter will get released. So most of the ladies, they have, after menopause, they have stress urinary incontinence. Okay, so when levator ani gets weak, the stress urinary incontinence occurs. So what are how we can diagnose the stress urinary incontinence? First of all, by the stress test, we will make the patient to lie on the lie in the lithotomy position, and then we will ask that patient, now you increase the abdominal pressure, now you cough or laugh, and if the urine gets leaks, then we can understand that it is a stress urinary. Other test is Boney's test and Q-tip test. Okay, so what does we do in Boney test? Per vaginally, we support the levator ani by 2 fingers. So that weakened levator ani is supported by our 2 fingers. And now we ask the patient to cough, and now because we have supported the levator ani, now no stress urinary incontinence is there. This is Boney's test. It is also known as Marshall-Boney test, and there is also one Q-tip test. Okay, what are the treatment? Conservative treatment is pelvic exercise, Kegel exercise, and the drugs which we give are alpha adrenergic agonist or SSRIs. Today itself we learned that for premenstrual syndrome, SSRI are the drug of the choice, and also for the for the stress in urinary incontinence, SSRI are the drug of choice, or the alpha adrenergic agonist. Okay, TVT is the transvaginal tape, which is done to strengthen the levator ani, or transobturator tape. So that are the OPD procedures which we do in the ladies who are suffering from stress urinary incontinence. Kelly stitches also apply, and Birch corpus suspension is also done. So the most good is the TOT, and the second one is a TVT. Okay, now let's study something about urge incontinence. It's the second last slide. Okay, don't worry. So what is urge incontinence? In this, the bladder muscle, it becomes overactive. So whenever a person has urge to pass, this bladder muscle contracts fast. Okay, so the urine leaks. Okay, how we diagnose this? We diagnose it by asking the patient the history or frequency of micturition. Of course, it is increased both in day and night. Whenever the the bladder gets filled, this bladder muscle gets contract. Usually the bladder muscle contract when 150 ml of urine is filled, but this in the urge incontinence it contracts at 50 ml itself. Okay, the treatment is bladder training exercises, anticholinergic, tolterodine, and all these anticholinergic drugs are there. Here, as a whole, the bladder muscle is hyperactive, so we have to do cystoplasty or diversion of the urine tracts. Now let us see genital fistula. What is genital fistula? Now here the fistula has become between the urinary and the genital tract. Communication is there. So most common is the vesico-vaginal fistula. That is, there is a communication of fistula has developed between the vesico, bladder and the vagina. Now the urine will leak from the vagina. So in the urine incontinence, the urine was leaking at inappropriate time, but here in the VVF, the urine leaks from the vagina. So these are two different things. Okay, don't mix them. Most common cause of VVF is obstructed labor in India, because they mishandle the patient a lot in this nice. Okay, बहुत कम हो गया, but still it is occurring in India. So most common cause is obstructed labor in India. Otherwise, in the other world, in the developed country, the cause is hysterectomy injuries. Okay, we investigated by methylene 3 swab test, and this is the first test we do, and but the investigation of choice is of course cystoscopy. The treatment is let's go repair. Once it is repaired by the let's go operation, then the patient has to maintain 3-month abstinence, and 1 year the patient has not to conceive. Okay, that was all.